Our next speaker is Dr. Ernest Mandel, who's an assistant professor of medicine at Harvard Medical School, and he's the executive vice president of healthcare and chief medical officer of Hebrew Senior Life. He's a nephrologist and a geriatrician, and will be best suited to talk to us about geriatric nephrology.
Thank you, Jamil. And thanks for this opportunity to share on a topic that's very close to my heart. I also know that I'm the last thing that stands between you and dinner and a break, so we'll try to keep this efficient, and I'll stick around at the end for questions as desired. So on disclosures, I have no relevant financial relationships. So what I'd like to do, and you'll see that actually there's more material in your materials than I'm actually going to go over today, so there's other things for you to reference at other times. But I'm going to focus very specifically on geriatrics for nephrologists, and then talk specifically about pre-ESRD care in the aging patient, and then talk a bit about conservative management as well. And as you'll see, there's some other topics in the materials for your review on your own time as well. So first, as far as geriatric assessment for the nephrologist. So the geriatric assessment is a multidisciplinary assessment. It's a battery of assessments that assesses the older adult in terms of their cognitive function, in terms of their mobility and their gait and their balance. It assesses their functional dependence and independence. It reviews their symptomatology, pain, depression, continence, other such symptoms or symptomatology that's typical for older adults. It also reviews their support structures, family, social, and even financial. And then, of course, it also includes a discussion of goals of care and advanced directives, encouraging the identification of healthcare proxies and the like. One important concept I think that's we need to talk about and frame for ourselves is the concept of frailty. And frailty is a concept, and it's also a research definition. The concept of frailty is a decreased functional reserve, which is to say that there's something about the aging process that means that you might not be able to tell immediately that I might have decreased functional reserve, but it manifests when I'm under stress. So for example, if I'm walking down the street and I miss the curb and I trip and I fall on the sidewalk, I'm less likely to fall because I have the ability to stabilize myself when I'm younger. My vibration sense is intact, and my position sense is more intact. And also I have more intact musculature. And even if I do fall, I'm less likely to suffer a fracture because of hopefully bone health and the like. But if I'm an older adult, that same trip can lead to a fall and a fracture, because I can't steady myself as easily because my vibration and position sensing is not as good, and my muscle strength is perhaps not as good, and my bone health might not be as strong, and so I might suffer a fracture when someone else might not have. And so that's the basic idea of frailty. It's a condition that we experience or may experience when we age that means that stressors are going to impact us differently and perhaps more severely. There's also a research definition, and there are some various sort of telltale signs of frailty. These include significant weight loss over the past year, self-reported exhaustion, grip strength with a pressure manometer, slow gait and gait speed, and then also a self-report of low physical activity. And in research terms, this free definition would apply if you have 3 out of 5 of these. There's also increasing work in something called a frailty index, which is based on claims data, which is trying to identify within EHRs people who might be at risk for frailty based on EHR included data. That's in a lot, it might be much in the works, still being used in research, and can start to be used clinically perhaps soon as well. The relevance of the concept of frailty is that it's certainly highly prevalent in older adults, but it's also highly prevalent in people with chronic kidney disease. And that's actually independent to some extent of age. It's across all age groups. It's associated with outcomes in our dialysis patients. And so the real lesson is that it's not just an aging phenomenon for our dialysis patients. It's something about the experience perhaps of kidney disease itself. How do we apply this when it's this very fancy sort of equipment requiring condition? Well, a practical application actually is gait speed, because gait speed is associated with 5-year survival, and it's also associated with developing functional dependence. And gait speed is something that we can observe in the course of our office visit, and it can help us make assessments of a patient's likelihood of, for example, tolerance of stressors such as consideration of initiation of dialysis or perhaps transplant referral or any of the other sort of decisions that we need to make as far as aggressiveness of potential therapy recommendations. And so there's been studies of actually the waiting room to exam room test, which is something that we can do empirically in our office, where we time the steady state walk. And so if you assume it's about 20 feet from the waiting room to the exam room, you time that middle 10 feet. You give them a chance to sort of get up and start going. You also are cognizant that they're going to slow down as they get to the room. So it's that middle 10 feet. And if that takes them less than 3 seconds, then their gait speed is not concerning. But if it's a more than 3 second period to get across those 10 feet, then that's a sign that there could be signs of frailty. Again, frailty is a concept. It's also sometimes our gestalt. It's also something that sort of like we know it when we see it. But this is a way to maybe be objective where someone's not showing obvious signs. Another one of the conditions of geriatrics that we have to think about is the concept of polypharmacy. The definition is variable, but it's defined as a patient being on more than 5 or maybe more than between 5 and 10 medications. As I'm sure you can imagine, that makes most of us guilty ourselves of polypharmacy in our patients because of all the different medications we might have them on for blood pressure control and volume control and phosphate control and a whole host of other conditions. When one is experiencing polypharmacy, one has an increased risk of side effects, increased risk of drug-drug interactions, and then there are also hard outcomes that are increased by polypharmacy, especially falls and other such risks. And then the final part of sort of our Geriatrics 101 is what I call the 4 questions approach and how we interpret evidence and guidelines in the context of our patients. Because when we're thinking about geriatric populations, they're often not included in studies, or sometimes when they are, they're narrow enough exclusion or inclusion criteria that we really have to assess, like we always do, whether the study applies to our patient. But there are other aspects of the study that we have to think about as well. We have to think about the who, of course. Is this does this apply to my patient? Is it applicable given their clinical conditions? And then also there's the what. Was the outcome of interest to my patient? So if the study is a question of morbidity and mortality, or perhaps mortality, that might be of interest to my patient. But if it's 20-year mortality, that may be of less interest. And of course, if my patient also is more focused on their comfort and quality of life, an outcome of mortality may be of less interest to them than some other outcomes. And then we also have to think about the time horizon, right? So prevention of advancing of CKD might be relevant to a 40-year-old on a 20 or 30-year time horizon, but may very well not be to my 80-year-old patient. And then, of course, there's always attendant risks of any treatment that we're choosing, and we have to think about what are the attendant risks for our patients. We've got to ask ourselves these 4 questions whenever we're thinking about the evidence, and we'll do an example of that shortly. All right, so to ground us, we're going to talk about Mr. Z. Mr. Z is an 82-year-old male who's in assisted living. He's mainly there because of his spouse's limitations, and he's referred for CKD management. He's got stage 4. He has hypertension and osteoarthritis. His baseline creatinine is now 2.4, and he's had this. His CKD has been associated with some AKI episodes from poor oral intake, while he's been focused on caring for his wife with Alzheimer's disease. So the first question we're going to ask ourselves is to think about access for Mr. Z, as he has an eGFR of 24. He's in stage 4 CKD, and one of the things we want to think about is, do we consider or refer him for access? So what are some of the considerations here? So, of course, we have to think about the risk-benefit. We want to avoid infection in this patient should he start on dialysis with a catheter. We also have to think about the procedural risk and inconvenience of the placement of permanent access. And we have to think about the success of that as well, primary versus secondary patency. There's a single-center study that showed that for individuals over the age of 80, you can expect about a 40% primary patency, but a 90% secondary patency at 12 months, which is to say that you have to at least expect you're going to have to go in a second time in order to get this access working, whether it's a simple procedure or even a redo surgery. But the likelihood, though, of success after a little bit of extra effort is very high. That said, you might need to leave as many as 12 months before you anticipate starting dialysis with that access. And then, of course, it's the competing risk of death, because while we don't want to start our patients on a catheter, we want to start them with a permanent access. We also don't want them to die with an unused fistula because we placed it prematurely because of their competing risk of death and they died from another cause long before. So there's some studies that I think we can focus on, but let's remind ourselves of our construct. So first, the who. Are we going to think about preemptive placement, or are we thinking about after planned or acute catheter start? What was actually studied in the studies we're about to review? We also want to think about what's the outcome we're trying to avoid. Is it preventing infection? Is it mortality? What's the outcome of relevance to our patient? We have to think about the time frame to end-stage kidney disease compared to the life expectancy of the patient, and also recognizing that most catheter infections often occur in the first 6 months, which might raise questions about preemptive placement versus start and placement at start. And then finally, of course, the risk is not used, the risk it fails to mature, and the risk of any procedural complications that can result. So a couple of frameworks to think about based on some studies on preemptive access creation. So Kurella Tamura in California looked at a study of the number needed to treat to prevent one access-related bloodstream infection. They inputted life expectancy for their patients, an access-specific infection rate, and that yielded a lifetime bloodstream infection rate for each access type. And then they assessed the absolute risk reduction, and then the reciprocal of that was the number needed to treat. And what they found was that for individuals over the age of 80 with average life expectancy for preemptive placement, the fistula versus graft number needed to treat was 33, and the graft versus catheter was 2, which this really suggests that in this population, one might consider a graft instead of a fistula because the likelihood of success and prevention of a bloodstream infection might actually be higher for the placement of a graft. Now, of course, this has to be an individualized question for the patient, and each patient's different. But certainly there are risks of clot and other thrombotic or other side effects of a graft placement have to be considered as well. But this does seem to suggest that a graft might be preferred for older adults. I think the other thing to point out is the number needed to treat of 33 of fistula versus graft is not that different from a colonoscopy to prevent colorectal cancer. And so on the one hand, we do colonoscopies very routinely, but not so much for people over the age of 80. And so just like with our Choosing Wisely campaigns, where we've focused on whether or not to do certain cancer screening in our dialysis patients and being wise in choosing and recommending cancer screening for dialysis patients, it may also be that a strict fistula first approach may not necessarily be appropriate for our older adults. Another study of interest done in Boston out of the Beth Israel Hospital by Bob Brown and colleagues wanted to look at whether the benefit of fistula first was truly about the fistula placement or perhaps about the pre-ESRD care. And so what they did was they looked at patients who started dialysis, with a fistula versus those who started with a catheter but had a fistula placed that was not ready. And then otherwise those who started with a catheter alone. And what you can see is that curves 1 and 2, which are fistula start or fistula in place but not ready, and so catheter start, those curves are fairly close, whereas the adverse outcomes really are more associated with the survival is more associated, the lower survival is associated with the catheter starts. And so what they suggest is that it actually may not be so much the actual fistula and starting with the fistula that improves the mortality, but just the fact that they had closer follow-up with their nephrologist to have pursued a preemptive fistula placement, whether it succeeded or not. Again, there's still a difference even between the first and the second curves, but it seems like they're somewhat tighter and closer, and maybe most of the benefit actually is in the pre-dialysis follow-up than it is in the actual fistula placement itself. Again, these are studies that are meant to at least give us pause and think about whether the fistula first approach is the best individualized approach for our patients. We ultimately have to help them come to their own shared decision, but this gives us some perspective on whether we should be dogmatic about fistula first for this population. And then the final similar study done out of North Carolina by Rashida Hall and colleagues, this was a cost effectiveness analysis. I won't spend too much time on this just in the interest of time, but their basic conclusion in this cost effectiveness analysis was that if the patient's life expectancy is more than 2 years, then a fistula is cost saving. If life expectancy is less than 6 months, then neither is cost effective. And then it's sort of in that 6 month to 2 year range where maybe a graft is a better choice than a fistula, sort of similar, but on a cost effectiveness basis to Karel Tamura's result before on the number needed to treat. This study had a lot of limitations. It was quite nuanced. But I think what we can say is that there's definitely, cause to consider what the right access approach is and individualize it for our patient. So, of course, it's not just about infection risk. There's quality of life considerations. Can my patient bathe with a catheter? What about the pain of needle insertion? Maybe they're needle phobic and they don't want to have needles under any considerations. There's also behavioral concerns, which can go both ways. We don't want them to pull out the catheter because that could be catastrophic. Of course, needle dislodgement could also be catastrophic in a dialysis unit. And so we have to think about some of the behavioral considerations for our patients perhaps as well as part of the individualized decision and recommendation about access placement. So again, it's a patient-centered, individualized decision. We have to take into account these infection risks, the life expectancy, the likelihood of success of the fistula in concert with our favorite transplant or vascular surgeon who's placing the fistula, the quality of life concerns and other behavioral considerations for our patient in making an individualized recommendation. So let's go back to our case. Mr. Z is now 84. His wife has passed away. He had a prolonged hospitalization for flu over the winter, and now he's in a nursing home. He's seeing you in follow-up of CKD. He's lost 10 pounds in the past year, which should hopefully make you think a little bit about the possible risk of frailty in this patient. His creatinine is now 2.9, so it's declined a little bit. And here are his other labs, including his electrolytes. He's on metoprolol, amlodipine, and furosemide, and he's also taking acetaminophen for pain. So we want to address his acidosis because we see that his bicarb is 17. So here's a little board-style question. Which of the following is the most appropriate next step in management for his acidosis? Do we prescribe sodium bicarbonate, 1,300 milligrams 3 times a day? Do we not change management at all? Do we add midodrine for blood pressure support, or do we discontinue the acetaminophen? Give folks a few moments to think that through and share your thoughts. All right, looks like we have a quorum. Actually, the preferred answer here is to discontinue the acetaminophen. And so what we actually have here is an anion gap acidosis from pyroglutamate or from 5-oxyproline. This is due to depletion of glutathione from the chronic acetaminophen use, and that leads to accumulation of the pyroglutamic acid or the 5-oxyproline and leads to the acidosis. It's associated with CKD and can be unmasked also with malnutrition. And the important pearl here is that in nursing homes, because of wanting to avoid opiates for pain management, because especially these patients were avoiding NSAIDs, standing acetaminophen is a very common practice in nursing homes for proactive pain management. And patients can be on up to a gram TID of standing Tylenol for months at a time. And so this is still not a common diagnosis, of course, 5-oxyproline but we've certainly seen a handful of cases in facilities I'm affiliated with over the last 2 to 5 years. And so it's just something to be aware of and to be looking at that med list for standing Tylenol in these patients. Of course, we want to be patient-centered, so we don't want to unmask pain. So maybe we would switch it to as needed, or many times they're using 1,000 milligrams 3 times a day. And so we could either lower the dose of Tylenol slightly if they really need the pain control. So we do want to be individualized and patient-centered, but discontinuing or reducing the Tylenol is the right answer here. All right, so back to our case with Mr. Z. So he seems to be in a new steady state with his advancing CKD4, and you want to talk about his thoughts about ESRD management. You present dialysis and conservative management as viable options, and he asks, what's the difference in survival and quality of life on these two options? So let's talk about conservative management first. There's a lot of emerging and continued interest in conservative management. It's obviously characterized most commonly by non-dialytic therapy, but the real question is it more than just not dialysis? And it's variously termed. I'm sure each of you might use your own term. Some call it medical management without dialysis. Some people call it conservative kidney management, maximal conservative management. There's a whole bunch of different names and acronyms that have been applied to this concept. So what exactly is it? So number one, it still involves disease management and prevention of progression as much as possible. It also involves a focus on symptom management and also advanced care planning and communication. These are sort of the three pillars of conservative management. When we talk about both disease management and symptom management, we're talking about the management of volume, so diuretics, perhaps oxygen if there's shortness of breath. Potassium management could be with medication review, diet, perhaps with a potassium binder, but that really depends on the goals of the patient. Phosphate, again, with dietary or perhaps binder therapy. And then, of course, anemia, whether it's with erythropoiesis-stimulating agents or iron infusion. And to some extent, these treatments, this management, while it is disease management, with the perhaps exception of potassium, you could also make an argument that there is a symptom component, right? Anemia can contribute to fatigue, phosphate to pruritus, volume to shortness of breath and dyspnea. And so even managing these disease components might very well actually fall under symptom management to some extent. And then there's also direct symptom management. The pruritus can be managed with emollients or antihistamines, and of course, dietary restriction if within goals of care. The nausea that one might experience with uremia with antiemetics. The pain, which is certainly a significant part of the geriatric experience in general, and certainly for patients with CKD. Making choices, of course, that are appropriate for their renal function. And then other syndromes like a restless leg syndrome and muscle cramps, managing those as well, as they are common in our advancing CKD patients. And of course, all these recommendations and decisions are in the context of the patient's goals or wishes. If they really want a milkshake, we're not going to stop them with a phosphate restriction or anything like that. It's really in concert with their goals. The concept of conservative kidney management imagines that unlike in diseases like COPD or ESRD, where one tends to have an inexorable decline in functional status that is punctuated by hospitalizations and rarely returning to normal, the concept is that with CKD5 without dialysis, one might be able to have a preserved functional ability for a prolonged period of time until such time as they move towards the end of life and have a rapid decline in their functional status. And so the goal is in that sort of purple circle is to preserve that functional ability as long as possible by making choices geared towards, to some extent, disease management, but certainly symptomatology and avoiding dialysis as long as possible, and then foregoing dialysis when the time might present itself. So what about this question on survival with conservative management? So this is very challenging to study. You can't really do a randomized controlled trial of this. Patients tend to choose one or the other. They choose renal replacement therapy or they choose their conservative management. It's also a question of when does the clock start, right? Does it start when they first get CKD stage 3? Does it start when their potassium gets over 6? Does it start when their GFR is less than 15? Like, you can imagine all different methodologies to study this. On the other hand, there's also new causal inference methodologies that can allow us to do a study that, while not a randomized controlled trial, can seek to mimic one. And we'll talk about one shortly. So the first study to look at is the De Silva Gain study from 2012 in CJASN. This was in a low clearance clinic, which meant for them a GFR of less than 15. Patients chose a modality, conservative kidney management or a modality of dialysis, and they sort of reassessed or recommitted at regular intervals. They did a propensity score analysis to control for selection bias. And what they found was the median survival was 30 months for patients with CKM versus 43 months with those on dialysis. So a little over a year, about 400 extra days of survival for those who chose dialysis. But one of the things they noted, which I think is important for us in thinking about this and advising patients, is that choosing those who chose dialysis were dialyzed a median of 326 days of those 43 months. And what that essentially means is that perhaps on average, 80% of the actual survival benefit were actually just days spent undergoing dialysis. That doesn't include being hospitalized or procedures on their access or anything like that. Which is to say that while they certainly survived more days and lived an additional year than those who chose conservative kidney management, those days may not have been their optimal quality of life. Of course, it depends on the patient. If the patient was hoping to get to their granddaughter's wedding and that granddaughter's wedding was at the 40th month, then they certainly chose well in choosing dialysis. But if they didn't have such a sort of time-focused goal, and they wanted to maximize their quality of life and time spent at home as opposed to in the medical system, one could argue that maybe CKM would have been a good choice for them. Here's just the graphs where you can see the changes in survival. The first two are your dialysis and PD curves, and then the bottom curve is those who chose conservative kidney management. And you can see the curves separate, relatively quickly in roughly the first 6 months, and maintain that separation over time. The second study to talk about is the Verburn study. This was a retrospective single-center study. People chose an enrollment, which is about less than 20 for the most part. The survival from the time of decision for those over the age of 70 was 3 years for renal replacement therapy and 1.5 years for conservative management. So again, this is a little further upstream, so the survival was longer in both cases, but the difference was not hugely different. It was about than the Silva Gain study. It's about a year or maybe a little bit more of decreased survival in this case. This was an intention to treat analysis, and it's noted that many in both groups died before they even got to an eGFR less than 10, which of course raises questions around power. It also raises questions as to whether or not they were studying the theoretical decision as opposed to any actual modality difference. The similar to the Brown study about fistula first, catheter last, and the pre-dialysis nephrology care, maybe they're really studying conservative management versus usual care. And if we incorporated conservative management in some aspects into our usual CKD care, maybe we would find the best of both worlds. They did find that for those 80 years of age and older, their survival was the same for those on dialysis and those on conservative management, which was a notable finding in the study. Although, again, given the number that actually reached 80 years of age and the number that actually went on dialysis, the power was very limited for that analysis, but as what they found, no difference. And here you can see those graphs, and they're in your materials. And then finally, one last study. This study in the Annals of Internal Medicine from a couple of years ago was a targeted trial. The idea here is a sort of a new causal inference methodology where we use a simulated randomized controlled trial using our observational data. This was studying people who started dialysis within 30 days of an eGFR less than 12 versus medical management, and they analyzed by both intention to treat and per protocol. There was no difference in survival for intention to treat, and that's mostly because people crossed over to dialysis when push came to shove. So it seems like we're more studying whether or not they initiated dialysis at eGFR less than 12 versus any decision about their conservative management or not conservative management. In the per protocol analysis, there was slightly longer survival and less time at home, which is also notable. And then again, for those 80 years and older, survival was longer and time at home was shorter with dialysis in both analyses. So slightly different finding than the Verburn study, but in terms of quality of life, less time at home for those 80 and older. So that's survival, and we'll summarize that shortly. The other question is quality of life. So we do know that the initiation of dialysis is associated with functional status decline. That's been shown by Karela Tamura in the New England Journal. Those who are institutionalized, meaning they go to nursing homes on dialysis, they have functional decline upon initiation of dialysis. And even in the community dwelling elders, there's been a reported increase in dependence after initiating dialysis. With conservative therapy, the Silva Gain study thought that there was perhaps in one of their analyses a preserved satisfaction with life score, which might suggest a preserved quality of life on conservative therapy compared to dialysis. And then there's also the question, of course, of symptoms, which I'll just say quickly. The symptomatology of CKD, end-stage CKD without dialysis and with dialysis is fairly similar. You can see that shown here with all these, essentially all these non-significant p-values. It's not surprising that our patients experience a lot of these similar symptoms with or without dialysis. But one of the challenges is how these are studied, because if you ask a dialysis patient, have you experienced shortness of breath in the last week? They might say yes, but it's the dialysis that actually relieved it by removing fluid. So it's a little bit hard to say that there's no symptomatology benefit to dialysis, but at least there's some equipoise here. I'm going to move quickly through this particular study. This was a study a couple years ago looking at quality of life a year before dialysis and then 6 months after initiation of dialysis. And they found that patients' quality of life was actually preserved upon initiation of dialysis. That's all these, both the green and the blue curves sort of flattening after the start of dialysis at that dotted line. There was a lot of missing data, so it's a little bit hard to make conclusions. And there's also an interesting concept, which is that the patients might have actually had a change in their quality of life considerations as they aged, which is something called response shift theory, which is an interesting concept, which is that people might change their minds as they age. Or the way I think about it is, if you ask me, do I want to play tennis or do I want to play pickleball, I might swear off pickleball and say I'll never play pickleball. But as I might become, less active and I have to choose between pickleball and golf, suddenly pickleball might look really good. And so this might be what happens as people get towards dialysis. They experience, whatever disease burden that they might have, or they think about, their prospects for survival or more near-term death. They might, of course, frame shift their preferences and be more receptive with dialysis. And so it's a little bit hard to say if quality of life is necessarily preserved with dialysis. It does seem that there's some studies that say it's preserved without dialysis. So this sort of leads us to a revised construct around thinking about conservative kidney management and how it might be experienced from a functional perspective. And that's this notion of sort of a best case, worst case, and most likely scenario. And the best case scenario might be that starting dialysis at the dotted line there, it might actually preserve one's functional status. The worst case scenario is that it gets bad very quickly. And then the most likely might be somewhere in between. And this is something we can help use in guiding our patients about their decision making. So we'll just end with a couple of quick questions. Which one of the following statements about conservative management is correct? A, quality of life with conservative management and dialysis are equivalent. B, survival with conservative management is equivalent to dialysis for patients under 65. C, survival with conservative management may be similar to dialysis for some patients. Or D, survival with dialysis is higher than with conservative management for all patients. Wait for a couple more responses. Or maybe we'll just move forward. It may not be working. So in this case, survival might be similar based on the Verburn study. There are other studies that have also shown that with certain comorbidities, one might have similar survival, and the other ones, as you can see, are not correct. And then one last question: which of the following is true with respect to outcomes after dialysis initiation for this patient? A, his quality of life will improve. B, he'll need to be in a nursing home. C, he'll require fewer hospitalizations. Or D, he may become more functionally dependent. Give folks a few seconds on that. All right, and in the interest of time, yes. So this is indeed D. He may become more functionally dependent. Both community dwellers and those who are institutionalized, that has been found to be the case. So our summary, conservative management is more than just no dialysis. With respect to survival, we at least have equipoise that for some populations, survival might be similar. There's, of course, quality of life considerations. It might be preserved with conservative management. And of course, we have to make sure that we manage symptoms. But overall, what this tells us is that conservative management might be a viable pathway, again, individualized decision-making for our patients. But based on survival data, based on quality of life data, there certainly could be reason for one to choose conservative management over dialysis. And we can help in the shared decision-making with our patients. So geriatric nephrology is an approach. It's not just old kidneys. CKD care needs to be individualized for our older adults. We talked about access considerations and whether fistula first is really one size fits all for this population. We talked about conservative management, and at the very least, there might be enough for equipoise to say that it's a reasonable choice between the two, depending on the patient preference. And that's all I have, and I'm happy to take any questions.
Thank you very much, Ernest. That was a great talk. I'll probably make it sweet and easy for our attendees who have been here for the whole day and ask only one question. Is serum creatinine an indicator of mortality for stable patients, CKD? I'm assuming when the GFR is below, 10 and they're still refusing dialysis.
As we know in older adults, creatinine isn't always the best measure because it's confounded by, frankly, by frailty, right, by their muscle mass and the like. I haven't seen data that looks specifically at either a creatinine or a GFR is associated with mortality when we get specifically that low. I think anecdotally, we've all experienced some patients who seem to have the consequences of uremia and or hyperkalemia with GFRs even above 10. And we have some patients who can get as low as 5 or 6 and be okay. So I can't really answer that there's a direct association in this older adult population that correlates directly. But I also would say that we tend not to measure it as often in this older population when they made a choice against dialysis. And so it's sort of a question that maybe could be answered in the future with some large data sets, but I haven't seen it yet.
Great, thank you. And then I want to thank all our attendees. In fact, another question came your way. So my dialysis unit tracks fistula rates and pressures me to place fistula. How do you communicate appropriateness of access to administrators? That's a tricky one.
Yes, that is a very hard question because unfortunately dialysis is still one size fits all. And frankly, it's not just about access, although that is part of it, but it's about PTH management and all of the QIP components that we're sort of held accountable for. And while this is good on a population level, it doesn't allow us to individualize care for our older adults. There is some movement towards allowing for more individualization of dialysis. The VA has been a leader in that. And there's some hope that there might be some loosening for a certain population. It'll be based on age, and the talk is maybe either over age 80 or over age 85. There's some sort of disagreement about where to draw the line. But it is a definite challenge right now because we are judged based on our rates of permanent access, our lab control of various comorbid conditions. So it is a challenge and something we need to continue to advocate for to allow us to individualize, at least for the older adult or the frail dialysis population, regardless of age. Definitely a challenge.
Yes, thank you very much, Ernest. And then I want to thank everyone for staying with us this long day, and then see you tomorrow morning. Thank you.